Good evening, doctors. My name is Ankur Gautam, and I'm on the behalf of FDC and Med Talks. I welcome you all to another episode of 52 Weeks Diabetes Essential with Dr. Sanjay Kalra. And as Holy month of Ramadan is around the corner, we have planned three lecture series, especially for Ramadan, as new development in diabetes can be helpful in your diabetes patients following Ramadan Holy month. Now, moving forward with today's topic. Today's topic is Ramadan fasting and health. And today's session is brought to you by your hydration partner, Inrazal Zero. And I would like to welcome our host, Dr. Sanjay Kalra, sir, President-elect South Asian Federation of Endocrine Society, to start the event, sir.
Thank you, Ankur, and good evening, everybody. Warm welcome to today's program. Today is a special program. Like Ankur said, this is the first in our series of three topics on Ramadan. This is the month of Shaban, and we have about three and a half weeks more for Ramzan to start. It's a matter of great pride for me to be able to invite one of the most dynamic endocrinologists of our country. Warm welcome, Dr. Shaila Sheikh, madam. Dr. Shaila Sheikh is senior
Thank
endocrinologist in Mumbai, working at Saifi Hospital and her own clinic. She's a member of the executive committee of the Endocrine Society of India, and her words will speak for herself. Uh, Allow me to shift to Urdu, Dr. Shaila, though I understand that you yourself, आपका भी हाथ तंग रहता है उर्दू में, but that is an understatement. but
Actually,
but there are multiple things you see that are involved in creating a good speaker. The first is called talim. Talim means education. Another Urdu word is tarbiyat. Tarbiyat means training. And then the third one is tajurba, which is experience. So there are many people who are educated. There will be quite a few people who are trained. And of course, with experience, you will gain experience. But to put all these together, you need tehzeeb. That is, tehzeeb would mean the art of speaking, the way of speaking, behavior. And all these four things Dr. Shela brings to the table. So, Dr. Shela, warm welcome. Uh, we have audience from across the country, and we'd like to listen to you about Ramadan, fasting, how it helps us in health, what is the definition of health, and how we can actually fast in such a way so that we can enhance our health.
so thank you for those kind words. I mean, you actually reminded me of my mom speaking because she always believed that, in spite of everything else, tarbiyat is the most important, and she was very strict about that. So, really, thanks for giving me those compliments, honestly. So today, what we are going to be speaking about, I mean, before I actually come to talking about the topic which you have assigned to me, Ramadan, as we all know, friends, we are in mid Shaban, and we are going to be having today is actually 13th of Shaban, 13, 14, 15 for the next 3 days. And a number of patients, we have been encouraging them to fast for these 3 days so that we know as to how they are going to behave during Ramadan. It makes things much more easier for us to understand how they are going to be behaving in Ramadan. Ramadan this year again is going to be coming in the summer months. It is going to be hot, and in a number of, I mean, it's going to be hot in our country in most areas, and most importantly, with the global warming, I mean, the north is it's said that the north is going to have a much warmer summer this year than ever. So, wishing everybody a very, very happy Ramadan, a very safe Ramadan from both of us out here. And before I actually get to, can I have the slides, please, Anna? And before I actually get to talking about Ramadan, I'm going to talk to you a little about what exactly are we talking about when we're talking about fasting per se. When we're talking about, at this point of time, a lot of us very, very casually use the word intermittent fasting. But when you actually talk about the word intermittent fasting, what you realize, next slide, please, what you realize that you're talking about a number of ways in which potentially a patient can, fast. But there's a very big difference when you talk about, intermittent fasting in a context of just health, and when you talk about intermittent fasting, which Ramadan is a prototype about in a religious context. Because when you're talking about intermittent fasting in the context just of health, and you are following a certain regimen, be it an alternate day fasting, be it a modified fasting regimen, be it time restricted fasting. Again, I mean, time restricted feeding, if you call it, or you talk about time restricted fasting, they are a little different from religious fasting, because religious fasting has a certain spiritual fervor which patients, even if they are not fit to fast, or even patients who you as a clinician may feel may not be in the best situation to fast, patients will still insist on fasting. We also need to keep in mind when we are having these conversations with our patients during the fasting period, that our conversations invariably have to begin with statements like, I want you to fast. I honestly think that we all should be fasting, but it is very important that you are healthy while you fast, because the Quran exempts everybody who is ill from fasting, because no bodily harm is allowed in any religion. And Islam is similar to all other religions, where we say that it is very important that you protect your body at all costs. And it is important that we understand this difference when we're talking about intermittent fasting and Ramadan fasting, though scientifically, Ramadan fasting, as I said, is also intermittent fasting, for the simple reason that once we understand this difference between these two areas, it would help us as a clinician address our patients' concerns better, understand where they come from, the space where they come from. Because when you're talking about fasting, Ramadan fasting, a very important point that I would like to put across over here is that kids fast right from the time they're maybe 4, 5, or even earlier, sometimes where people feel that it is okay if they fast. And at the age at when they develop an illness, and then when we request them not to fast, we have to tell them that these are the reasons why we are not allowing to fast. Some of the other religious fasts, as we all know, Lent is going on also at this point of time. We are used to treating our patients when they're fasting in the Jain fast, the Navratri. There's so many different kind of fasts, and whenever your patient is fasting, as I said, it's very important that we understand, next slide please, what exactly the fast involves. Because when you're talking about a fasting condition, we know release of insulin is controlled by glucose. The glucose produced by the liver, as we know, is usually used by the brain, because glucose uptake is not dependent on insulin. But insulin otherwise controls the glucose production by the liver, next please, and limits the release of NEFA from the adipose tissue. Now, what happens when you fast is, after 12 hours approximately, there's going to be depletion of glycogen stores in the liver. As a result of this depletion, there's a switch which occurs. And as a result of this switch, adipose tissue lipolysis is going to take place, which is going to increase production of fatty acids and glycerol. What is most important for us to remember is that in our diabetic patients, this insulin resistance prolongs the time it takes for this metabolic switch. And next slide, please. And that's the reason why you could potentially not have all the benefits that intermittent fasting can have on the body and brain. If I look at some of the benefits which intermittent fasting has as far as our biology is concerned, these are some of them which I've put up over here, which for us as clinicians is very, very important. Is we know now we're talking about intermittent fasting influencing cognitive function and network plasticity. We all talk about it as reducing inflammation. We are talking about it. We've always spoken about keto diets having influence on seizures and seizure related brain damage. We've been talking about fat tissue, where it is going to reduce again leptin, increase adiponectin. Insulin sensitivity improves with intermittent fasting is something which we have a huge amount of data out there. And not only that, it also affects your intestinal microbiome. And finally, some of the common systemic effects that you are expecting in a patient who's actually doing intermittent fasting is not only improvement as far as the central nervous system and the cardiovascular system goes, but improvement as far as glycemic control goes, immune system goes, and the risk of a number of chronic complications go. And the new, I would say, the new dogma which we all talk about all the time is healthy aging. What has been seen, a number of trials have shown at this point of time some very, very interesting data coming out, that intermittent fasting is also beneficial as far as aging is concerned. It does help you age much more healthily than other weight other lifestyle parameters are used, other parameters where we're not going to actually use medicine, to the point of time that we are now talking about intermittent fasting as actually a medicinal intervention. Next slide, please. And when you look at, as I've said, you look at some of the benefits which have a very, very important, influence for us. What we really look at is oxidative damage, energy metabolism, cellular protection, a lot of positive effect on lipids and glucose levels, and improvement as far as adiponectin levels go, and no really significant negative effect on metabolic control and the variables like insulin, C-peptide, HbA1c, lipid profile, and weight. Then why are you and me worried? What next slide, please? Because the reason we worry, when you look at some of the studies which have been done regarding intermittent fasting, these are obese adults. Next slide, please. In a nutrition clinic in Mumbai, what was seen that yes, there is a percentage change, next please, in the weight and waist circumference at different follow-up stages, but females showed a much better improvement. So, what is it that is worrying you? If I'm talking everything good, if everything is absolutely hunky dory, then why am I worried when my patient tells me I want to fast in Ramadan? Because it's a little different when your patient is fasting during Ramadan. And the reason I'm saying it's a little different, because not only does your patient abstain from food, what is important is your patient also abstains from fluids. So you are dealing with a potential situation of dehydration in these patients, because religious fasting of Ramadan involves no eating from sunrise to sunset. And in our country, that is going to translate into a 14 to 15 hours of fasting across the country. You would ask me what kind of difference it is would make, because I've just spoken about the benefits of intermittent fasting. It would not make potentially a difference in a healthy adult, in an adult who is not suffering from diabetes, but in a patient with diabetes it has a number of health related implications which I will just talk to you about. And what is very important for us to understand is that when the patient is fasting, there is no food, no liquids, and no medications which are taken orally. So all the oral intake is taken between sunset, when the patient breaks the fast, to sunrise next day, when the patient is going to actually consume something. Now, when you talk about how many Muslims actually fast, you would be surprised. Very, very surprised, I would say, because what surprises you is almost 67% of patients, mind you, these are type 2 diabetic patients who fast every day during Ramadan. This was the Creed study. When the Creed study was presented, actually, at that point of time, we still did not have SGLT inhibitors being used as extensively. We did not have our newer insulins being used as extensively, and we did not have as much of data as we have today. As of today, I think this number would be much higher, because as a clinician, you're able to stratify better. As a clinician, you have much more data to go to as far as fasting is concerned during Ramadan. And as a clinician, you have the advantage of being able to use newer molecules which do not translate into that much of hypoglycemia. But if you, next slide, please, if I actually put the data across over there, we are not only talking about hypoglycemia, we need to remember Ramadan fasting is a lot of feasting. And that is actually the problem in Ramadan in a significant number of patients, because with the emphasis on hypoglycemia, which, as I said, friends, is reduced with newer agents, we have never concentrated on the hyperglycemia. And even if we have concentrated on the hyperglycemia, it is such a deeply ingrained cultural thought process that when Ramadan is coming, you are supposed to partake of all the possible high calorie foods that are available to you. And it is almost, if I'm allowed to use the word, it's almost, I don't want to use the word criminal, but it is, sometimes patients do look at you absolutely aghast if you tell them that you're supposed to eat reasonably well, or moderate, at least in some kind of moderation, when they break their fast. Because though we are at all points of time asking patients to follow the Ramadan plate, we are all points of time asking the patients to consume more protein, more complex carbs. What patients actually consume are going to be a lot of sherbets, a lot of honey based food, a lot of dates, and a lot of fried foods during the iftar. And that is why the benefit that you accrue in a patient of intermittent fasting does not translate into the benefit that you would expect in a patient doing something akin to intermittent fasting during the entire month of Ramadan. But the data out there which we have says that yes, I mean the hyperglycemia that we see post Ramadan, post iftar, sorry, is sort of mitigated to some extent because of the prolonged period of hypoglycemia. And if you really educate the patient, monitor the patient during Ramadan, and understand the extent of hypoglycemia that you are seeing, you are able to adjust molecules much better now. And of course, with increasing education, our patients are also responding much better to understanding that they need to limit this feasting that they believe is very, very important that they indulge in during Ramadan. As a result of hyperglycemia, decay is something which we would expect, but the numbers are reducing. But yes, patients who are on SGLT inhibitors, please keep a watch for euglycemic decay, which Sir will talk to you about in the third edition of this entire series. As I said, dehydration and thrombosis is something we should be keeping in mind when we are talking about our patients fasting during Ramadan. Next slide, please. If I take this further on, what you would realize is when I talk about the real incidence of hypo and hyperglycemia, these are the numbers, friend. Again, an EPIDIAR study, which, as I said, is a decade-old study. And if next slide, please. If I come to the CREET study, which is relatively a little recent study, you would realize that yes, there is an increased incidence of hypoglycemia, definitely. But the hypoglycemia, if you look at this slide very critically, is the highest in North Africa, where still when this study was done, when there was a sub-analysis, it was seen that in this cohort, it was more sulfonylureas which were used. And it was actually surprising when you look at the data, and when you look at the Middle East data, that only 19% of patients had hypoglycemia. But when you go a little more closely and see this data, you would realize that this cohort actually had a significant amount of hyperglycemia also. So maybe that was the reason why in the Middle East we did not see as much of hypoglycemia. And as I said, both of them more or less mitigate each other. Next slide, please. And what this is a typical prototype of the blood glucose levels that you see in a patient who is fasting during Ramadan. In this CGM, as you would see just before iftar, you can see a dip. You can see a dip just before the patient is going to break their fast. And that's the reason we all the time encourage our patients to check their sugars just before the time when they're going to break their fast, because you are going to see this drop, and then you're going to see this subsequent peak which is seen after iftar in your patients as a result of the feasting that is done during the iftar period. Not only it is glucose levels which are influenced. Next slide, please. What is also very important, which we don't talk about much, is the sleep pattern. That is definitely decreased total sleep time, delayed sleep, decreased sleep period time, and a number of sleep issues which happen during Ramadan, for the simple reason that in most households, the time of prayer is increased during Ramadan, and a number of people are going to actually perform increased prayer during Ramadan, especially in the night time. So the sleep pattern is going to reduce, the duration they sleep gets reduced. And as a result of this reduction in the sleep pattern, it translates into increased daytime somnolence, which in a country like ours, where we are actually in the day following routine lifestyle patterns, it can influence your quality of life, because it can result in increased somnolence during the day. And the main why are we talking about sleep patterns? Because we need to understand that we do follow a circadian rhythm. And just one slide about the circadian rhythm, because personally, next please, I believe it is very, very important that we understand the circadian rhythm. We are now talking increasingly about circadian rhythms and how they affect our biology. And when we are altering this completely, this does influence even our hormones. For example, it is going to influence your your cortisol hormone, it is going to affect your melatonin hormone, and it can potentially translate into a significant amount of metabolic abnormalities during, if we are not very, very careful, and we do not really adhere to the mandatory amount of sleep, which is actually possible. If you sleep early, it is possible to get up at 4 a.m. But most of the households would have a sleeping pattern of maybe 12, sometimes 1, short sleeping patterns, then indulge in some sleep again in the morning. So very, very disrupted sleep pattern, which can potentially translate into hormonal issues, which we will get, which is again a very, very interesting subject. Next slide, please, as far as Ramadan is concerned. So when I look at some of the factors which influence Ramadan care, These would be some of the factors, be it your diabetes related factors, be it your Ramadan related factors, or be it factors concerning the individual. And if you really want to have a healthy Ramadan, next slide, please. It's very important that you risk stratify your patient, which we're going to be talking again, as I said, in the next edition, where you educate your patients regarding the entire physiology of fasting. You educate your patients regarding the importance of monitoring fluids, exercise, and so we'll be talking about medication adjustment and when to break the fast. This will be my last slide for the day. And back to Sir to have a fantastic conversation again regarding how we could potentially make this Ramadan a much more safer experience for all our patients who are planning to fast during Ramadan. Thank you very much.
Thank you, Dr. Shela, and warm greetings to you and messages from across the country. There is a message from Dr. Sheikh Shaigan, who is a community physician in Moradabad in UP. Also, good evening to you from Rahul Desai and from Love Humanity, a wonderful name. Dr. Shaigan thanks you for focusing on community health by spreading the good word about safe Ramzan fasting. Uh, a question from Love Humanities: can we use SGLT2 inhibitors in persons during Ramadan?
Uh, I really love the name. I mean, it's a very, very interesting name. Yes, we can use SGLT2 inhibitors during Ramadan, but what we suggest is that the timing of taking the SGLT2 inhibitor be shifted to iftar. It is very important that we also explain our patients to increase their fluid intake during Ramadan so that they do not have any dehydration. We also encourage our patients to actually come for a pre-Ramadan visit at least 4 to 6 weeks before Ramadan, so that if you're starting an SGLT2 inhibitor also for your patient, so in order that you do not face that increased osmotic diuresis that you see in the beginning of starting an SGLT2 inhibitor, that period is already finished before the actual Ramadan starts. Very, very important also that in a patient who develops any kind of genitourinary infections, that they come back to you, inform you. There is no increased incidence seen during Ramadan, but as a routine education, it is important that we tell our patients this.
Another question is SGLT2 inhibitors, can we use them as weight loss therapy in persons with pre-diabetes?
So SGLT inhibitors have not been approved as weight loss therapies in patients with pre-diabetes. There is no data and there is no approval that they can be used as weight loss therapies in pre-diabetes.
And same answer would be true for hypertension as well. If you use them, certainly the BP will come down slightly by a few millimeters mercury, but they are not potent enough to be used as monotherapy. Dr. Sheikh points out that SGLT2 inhibitors have many benefits for people without diabetes, for example, heart failure. But it won't make sense to use them as monotherapy if there's no other indication for weight loss or for BP control.
Very true.
Dr. Vinayak Sharma is also there. And then one more question from Dr. Nasira Begum. Okay, this question is depending upon the latitude, sometimes the fasting for Ramadan changes. If you are near the equator, the fasting duration is shorter, but it is hotter as well, Dr. Nasira. So it is tough. And if you are far away from the equator, then sometimes depending upon the season, actually, sometimes the fasting can go up to nearly 20 hours, I think. Is that correct, Dr. Sharma?
Yes, sir, very true. In the northern hemisphere, sometimes, for example, in the Scandinavian countries, the fasting period can go up to 20 hours, and even in the absolute southern hemisphere, they can go up to 20 hours. So our patients have only a window period of eating for 4 hours.
If your patient comes and says, Doctor, I want to try, I understand that I have diabetes for 20 years. You've done a risk stratification. I accept the guidance from the Holy Quran. I also accept the guidance from the IDF because all the ulema and all the doctors have got together to make this guidance in my favor. But still, I want to try fasting. So I want to try on a Friday. Then what kind of advice would you give? And what is the safety backup that this patient must have?
So if the patient, if you have a conversation with the patient and the patient says that I still want to fast, the first thing which is very important is risk stratification for us to understand what kind of risk this patient has. For example, if the patient is on very long term diabetes and he is on insulin, again, if he's just on a basal insulin, the risk stratification would be different. And if the patient is on pre-mixed insulins, for example, the risk stratification would be different. If the patient is on certain medication that have an increased risk of hypoglycemia, and those medications can potentially be reduced before Ramadan, to understand what kind of risk I mean, what kind of adjustments we can do, that would also help. The third thing, it's very important, sir, especially if you're deciding to allow the patient to fast maybe for a day, to understand how the patient's system is going to respond, is monitoring. Monitoring, if it is just going to be for a day or two, to understand, as we said, if you do it on 13, 14, 15, then SMBG is good enough for us to understand. We would request the patient to monitor before suhoor, 2 hours after suhoor, midday if possible, before iftar, 2 hours after iftar, to understand what kind of glycemic variability we are seeing and what kind of glycemic parameters we are seeing. We would also request the patient to continue following the diabetic diet that they are following, and not to actually follow the typical diet that we followed when we are breaking the fast. One date is allowed. I mean, we allow our patients one dates because dates are a good source of electrolytes and also have fiber. So it can be easily be one date can be consumed. I mean, the most important, sir, thing which we would also request is a family to get educated. I always believe that if you're allowing a patient to fast, and a patient who is requesting that, maybe they can be allowed to fast for a day or two to understand how their systems are responding. It's very important that we educate at least one more member of the family, so that in case of any kind of untoward event, the family member knows what is happening and can seek medical help immediately. So it's a combination of a number of factors which would finally translate into successful fasting. But our advantage now, sir, is that with newer molecules, newer insulins, better monitoring, more easy accessibility to help, to 24/7 helplines which are set up, it becomes much more easier. So that's why it's become more and more individualized process. And if you can individualize this, I think we can allow it in selective patients.
Yeah, I think there are many patients who maybe we could not have helped them fast maybe 20, 25 years ago with the older insulins, with the older oral drugs. But now, because we have newer drugs, we have such good monitoring systems available. I think now we can help them. Dr. Shela, you had spoken about diet. So one last question. When we speak of the menu for suhoor and the menu for iftar, we always think in terms of taste and then calories and carbohydrates. But what about cooking time? Should we not spare some time for the person who is doing the cooking? So,
I totally agree with you. I totally agree with you. But unfortunately, sir, it doesn't happen. It doesn't happen in any household, to be very honest, because the cooking time. So, for example, if the fast is if you're going to have suhoor at 4:30, the female member of the household has to get up maybe at least 1.5 hours before that to prepare a morning suhoor meal. In the evening, again, if the breaking of the fast is at 7, for example, most of the household will have their women folk starting from maybe 4:35 to see to that they are adequately laid in our table. Yes, I mean, so it is significantly difficult for the women folk, especially during Ramadan, to be honest, because there's a lot of balancing with the prayer schedules, with looking after the families, doing the cooking in the kitchen. It is really difficult, and they really need a lot of empathy, sir, to be honest, and a lot of care for them to understand that they need to look after themselves also. Most of the women folk will tell you that even thyroid medication, they'll tell you, ma'am, I just forgot I had to make my sur, and thyroid levels are really, they are totally go for a toss post Ramadan. So I totally agree with you, sir.
though we would like to remind everybody that in suhoor, if you take more of sugar, more of salt, more of spices, and more of saturated fat, that is ghee, you are going to end up being more thirsty during the day. So if your suhoor is simple, there is less sugar, less salt, less spice, and less ghee. Everybody will be less hungry and less thirsty during the day. So it helps in a more fulfilling fast. So maybe simple recipes are better recipes. They help in fasting as well. One question is, supposing somebody has pre-diabetes, this is one question, then can that person fast safely?
So if a pre-diabetic patient can fast absolutely safely, as long as the patient doesn't have any other comorbidity, like the patient
And if
is
the
not.
person, yeah,
Sorry.
if the person has pre-diabetes or diabetes and is on metformin, and now let us say the rosas will start after a week, suppose. So then, what kind of dose adjustment do we tell with metformin
So
monotherapy?
metformin, if the patient is on 1000 milligram, 500 milligram twice a day, the patient continues the same dose. If the patient is on 1500 milligram, we give 500 milligram at suhoor and 1000 milligram at iftar. The patient can safely continue fasting if the patient is on metformin, no problem whatsoever.
Thank you. So that answers this question from Love Humanity. It's been great, Dr. Shella, being with you. Half an hour passed by and we didn't even realize the time. Uh, I'm very sure more and more questions will come regarding Ramzan, and we'll be talking about the same topic next Sunday and the Sunday after that as well. And of course, if there is a question specifically for Dr. Shella, please feel free to reach out to us through your FDC team. We will get the message across to Madam, and she will do her best to answer. It is important to kickstart a dialogue, actually a multi-log amongst all of us. Like Madam said, safe fasting will be possible if the family is also involved. So we should begin speaking. And each and every stakeholder is important. The family members, the Maulvi Sahab, the Maulana Sahab, the Ulema. Uh, Recently, we had the KK Med Talk where we asked the Maulvi Sahab from Western UP, how many times do doctors come to you with a spiritual problem? You know, my patient wants to fast. I'm not very comfortable. What should I do? He said, nobody came to us. So we asked the doctor, why is it that you didn't go? And it's not that they were egoistic or anything. They were afraid that they thought the Maulvi Sahab will laugh at them. And so it's just about lack of communication. And unfortunately, because of lack of communication, the patients suffer, the community suffer.
Very true,
So
sir.
we sort of begun this communication at KK Med Talk for the general public, at Diabetes Essentials for our doctors. And we hope to continue this in the times to come. I'd like to thank Dr. Sheila once more. Thank you, madam, and thank you everyone for being with us. Thank you especially to Dr. Shaigan from UP and to Love Humanity. Dr. Ali Nazakat is also with us. Good evening, sir. And we'd like to hand back to Team FDC now for the vote of thanks.
Thank you very much, sir. Thank you for having me here. And thank you for everybody, including Love Humanity and Dr. Nazakat. Thank you.
Ma'am, it's been a wonderful day because last 3 years we have been doing this diabetes essential for every week Sunday. But today the content was very, very new, and I'm sure with the today's presentations of viewers, lots of doctors who are regular viewers as well as new doctors, probably we have registered around 3,000 doctors in our platform for next 3 episodes. We'll all get benefit because of your talking. Thank you very much. And with this, Sanjay sir has really designed this three topics. When I was going through the topics, I could see that first is by Dr. Sela, and the second is risk stratification, which is coming next Sunday, and the last will be end by Dr. Sanjay Kala. Wonderfully designed. I'm sure with these 3 weeks, everyone who is looking into our diabetes essential for long 3 years will get benefited in their practice. Thank you very much, and Jai Hind, sir. Jai Hind, ma'am.
Thank
Jai
you.
Hind.
Jai Hind. Jai Hind.
एक्सेलेंट सर आज का कंटेंट बहुत तगड़ा था सर